Yes, we are very much here. As somebody has said that woods are dark, lovely and deep, but I have promises to keep and miles to go before I sleep. Yes, we are all set for our next session on Medicine Endo. I have the pleasure of welcoming our esteemed faculty, Dr. Rahul Nikumbe, who shall be taking up this topic of medicine endocrine. Dr. Rahul Nikumbe has done his MBBS from Seth GS Medical College and KEM Hospital, Mumbai. He's done his MD from Guwahati Medical College and Hospital, Guwahati, Assam. He also has a postgraduate diploma in Advanced Diabetes Care and Clinical Endocrinology. Let us welcome this fantastic doctor, Dr. Rahul Nikumbe, who is going to take Medicine Endo. Over to you, sir.
Okay, good evening everyone. Am I audible to all? Okay, so all of you are tired? All of you are tired? So don't worry, relax. No need to write anything. So just you have to listen and you have to understand. Okay? So don't worry all of you guys, just relax, sit, listen, read and understand. We are going to discuss only concepts very fast. Okay? Medicine, endo. So let us start. Endocrinology. The most important part, we will start from the basic concept, pituitary gland. Pituitary gland, it is having two parts, anterior pituitary and posterior pituitary. Anterior pituitary secretes TSH, ACTH, LH, FSH, GH and prolactin. Posterior pituitary, it secretes oxytocin and vasopressin. Okay, first we will discuss prolactin. You must know normal secretion of all hormones. It is compulsory. If you don't know normal, then you are not going to understand any abnormal thing, that is medicine. So first, normal thing, prolactin is secreted by lactotrophs cells of anterior pituitary, and this secretion is inhibited by dopamine. Dopamine is secreted by arcuate nucleus of hypothalamus. So please remember, prolactin secretion is inhibited by dopamine. What is importance in medicine? If I give the drug which is dopamine agonist, it will decrease prolactin secretion. If I give the drug which is dopamine antagonist, it will increase prolactin secretion. Okay. Now who stimulate prolactin secretion? TRH, thyrotropin releasing hormone, stimulates prolactin secretion, plus VIP, vasoactive intestinal peptide, it also stimulates prolactin secretion. Okay. Next important point, prolactinoma. It is the tumor of lactotroph cells which is secreting lot of prolactin independent of everything. First basic concept in all tumors of endocrine, all tumor cells, they will secrete hormone independent of everything. Now we are discussing okay. Am I audible now? Am I audible now clearly? Am I audible? Yes. Now prolactinoma. Prolactinoma. This is the tumor of pituitary, tumor of lactotroph cells of pituitary, which is secreting lot of prolactin. So any tumor in endocrine, it will secrete hormone independent of everything. These are the tumor cells. So these tumor cells, they are secreting lot of prolactin. So prolactin level in blood, it will increase. So what will be the clinical features of increased prolactin? To remember clinical features of increased prolactin, you must know normal functions of prolactin. Normally prolactin is required for development of lactating glands. It is required for development of lactating glands. prolactin induces and maintains lactation. Prolactin decreases sexual desire. Prolactin inhibits ovulation and folliculogenesis. In male, prolactin decreases LH, luteinizing hormone, and prolactin decreases testosterone, so it decreases spermatogenesis. So simply remember, prolactin causes infertility in males as well as in females. How the patient will come to you? If patient is having increased secretion of prolactin, patient will have amenorrhea, galactorrhea, infertility. Galactorrhea, 80% of patients, they will come to you with galactorrhea. Okay. Now, if patient is having tumor of pituitary which is compressing optic chiasma, then patient will have bitemporal hemianopia. It is a visual field defect, but remember, it is not because of hormone. It is not because of increased level of prolactin. It is the clinical feature which is because of compression of optic chiasma, now this clinical feature, it can occur because of any tumor. So in exam they can ask you simple MCQ that which of the following is not a clinical feature of hyperprolactinemia. So they will give you all these four options. Please remember, visual field defect or bitemporal hemianopia, it is not the feature because of increased prolactin. It is the feature because of tumor compressing optic chiasma. Okay. Now, protocol for hyperprolactinemia. Whenever clinical features are present, now remember, in whole endo, whenever patient is coming to you with certain group of clinical features, specific group of clinical features, you are suspecting increase or decrease, that is hyper or hypo secretion of any hormone, your first step is to check that hormone level. It is the rule in complete endo in all diseases of endo. Okay. If clinical features are present and that hormone level is increased or decreased, only then you can say these clinical features are because of that hormone. If hormone level is normal, then it is not a case of endo. You have to find some other cause. Okay. Now, if patient is coming to me with amenorrhea, galactorrhea and infertility, I am suspecting increased level of prolactin. So my first step, I will check serum prolactin level. Normal prolactin level, it is less than 20 in males, less than 25 in females. If prolactin level, if it is more than 200, then most common cause is prolactinoma. Patient having serum prolactin level more than 200, most common cause is tumor of pituitary secreting lot of prolactin, that is prolactinoma. So remember this normal value and the value for prolactinoma. So now, patient is coming to me with amenorrhea, galactorrhea, infertility. I am suspecting prolactinoma or increased level of prolactin. My first step, I will check serum prolactin level. If prolactin level is increased, then I am suspecting a tumor of pituitary. So I will go for MRI brain, and there are two possibilities. It can be a case of microadenoma. It can be a case of macroadenoma. It depends on the size of tumor. If size of tumor is less than 1 centimeter, it is a case of microadenoma. My next step, I will start the drug dopamine agonist, cabergoline or bromocriptine. These drugs, they will decrease the secretion of prolactin. So after starting drug, I will monitor serum prolactin level. After starting drug, if serum prolactin level decreases, I will continue drugs, I will monitor prolactin, I will decrease the dose of drug, and then I can stop the drugs. But if after starting drug, prolactin level is increased, still it is not controlled, still it is more than 50, then I have to go for surgery. Transpenoidal surgical resection of tumor. Second scenario, suppose my patient is having macroadenoma. My patient is having size of the tumor more than 1 centimeter. In these patients, I will start drugs again. Please remember, whatever may be symptoms, treatment always start with the drugs. Even if patient comes to you with visual field defect, bitemporal hemianopia, first step you will start the drugs, because it is property of prolactinoma that after giving drugs, these drugs they decrease size of the tumor. Most of the patients they will give very good response to drugs and surgery is not required. So simply remember, in prolactinoma, whatever may be symptoms, microadenoma or macroadenoma, your first step is to start the drug, because dopamine agonist they decrease size of the tumor. Okay. Now, after starting drug, here I will monitor prolactin level, plus I have to monitor size of the tumor. Most of the patients they will give you very good response and size of the tumor will decrease. If size of the tumor decreases, you will continue drugs and then you will decrease the dose of the drug. But suppose if size of the tumor remains same, then you have to go for surgery, transpenoidal surgical resection. In both patients, after surgery, if prolactin level is increasing, then we have to go for radiotherapy. So only write down radiotherapy below surgery in both patients. After surgery, if prolactin level is increasing, you will go for radiotherapy. Okay, speed is okay? All of you are okay with the speed? Now, drug of choice for prolactinoma. Cabergoline is drug of choice in all patients. Whatever may be the symptoms, cabergoline, it is the drug of choice because it is long acting. Bromocriptine is preferred when pregnancy is desired. Sentence from Harrison. Bromocriptine is preferred when pregnancy is desired, bracket by female. Please remember, female patient coming to you with infertility, main complaint of patient is infertility, or female patient is desiring pregnancy, then drug will be bromocriptine. Otherwise, in all patients, drug of choice is cabergoline. Okay, so what is the answer for this MCQ? Can you give answer for this MCQ? So now a young married female coming to you with infertility, here answer is bromocriptine. Please remember, married female coming to you for infertility, patient is desiring pregnancy, answer will be bromocriptine. Next, growth hormone. Okay, in growth hormone, again you have to remember the normal secretion of growth hormone. Okay, anterior pituitary, it is having somatotrophs cells secrete growth hormone. Somatotrophs cells, they are stimulated by GHRH, growth hormone releasing hormone. Growth hormone, it will act on all cells of our body. What is important in medicine? Growth hormone acts on liver, vein. Liver is stimulated by growth hormone. Liver will produce IGF-1, insulin-like growth factor 1. Okay, so simply when growth hormone increases, IGF-1 will increase. If growth hormone decreases, IGF-1 will decrease. Suppose pituitary is normal, pituitary is secreting growth hormone, but patient is having defect in growth hormone receptor. Pituitary is normal, secreting growth hormone, but growth hormone receptors are not working. Liver is having growth hormone receptors which are not responding to growth hormone. So growth hormone level will increase, but it is not able to act on receptor. It is not able to produce IGF-1. So your patient will have increased growth hormone with decreased IGF-1. Your diagnosis is growth hormone receptor defect, growth hormone insensitivity. It is called as Laron's syndrome. It is a part of pediatrics. Now come to medicine. In medicine, most important disease is acromegaly. What is acromegaly? Hypersecretion of growth hormone. Hypersecretion of growth hormone. Now, clinical features of acromegaly: mental disturbances, insomnia, glaucoma, hemianopia, left ventricular hypertrophy, hypertension, osteoarthritis, hyperhidrosis, increase in the size of foot and hands, prognathism. Okay, now patient is coming to me with all these clinical features. What will be my next step? If patient is coming to me with all these clinical features, I am suspecting growth hormone hypersecretion. Just I told you, wait, if growth hormone increases, IGF-1 level, it will also increase. So my next step, I will check IGF-1 level. Okay, but it is a screening test. It is not confirmatory test. Reason, there are lot of causes of increase in IGF-1. It is not specific for only growth hormone. There can be any other tumor which is secreting IGF-1. So it is not confirmatory. Now I want to confirm my diagnosis. So confirmatory test is growth hormone suppression test. Another name of the same test is oral glucose load test. Now what is oral glucose load test? I will give lot of glucose to my patient. How much? 75 gram of oral glucose. When I am giving glucose to my patient, glucose level in blood, it will increase. Now this increased glucose, it will inhibit secretion of growth hormone, means it will inhibit somatotroph cells of pituitary, and in a normal person, growth hormone secretion decreases. Simply I want to tell you, glucose hyperglycemia in blood inhibit growth hormone secretion in normal person. Okay, normally remember, growth hormone increases gluconeogenesis, glycogenolysis, growth hormone antagonizes insulin. So simply remember, normally growth hormone increases glucose. Okay, G for growth hormone, G for glucose. Normally growth hormone increases glucose, and when normally glucose level, if glucose levels are increased glucose, it will give feedback and it will cause decreased level of growth hormone. Okay, this is normal. Now I will give 75 gram of glucose to my patient, and after causing hyperglycemia, I will collect blood and I will measure growth hormone level. After causing hyperglycemia, if growth hormone level decreases, then I can say my patient is normal, because I am able to inhibit the cells. If I am able to inhibit cells, then these cells are normal. If after causing hyperglycemia, growth hormone level is very high, it means I am not able to inhibit cells. If I am not able to inhibit cells, they are tumor cells. I told you, tumor cells, they secrete hormone independent of everything. Tumor cells, they secrete hormone independent of everything. You cannot inhibit tumor cells. So after causing hyperglycemia, if growth hormone level is very high, it means we are not able to inhibit cells. They are tumor cells. Now it is confirmed my patient is having a tumor which is secreting lot of growth hormone. Patient is having hyper secretion of growth hormone, and 98% cases they have tumor in pituitary adenoma secreting lot of growth hormone. So remember, most common cause of hypersecretion of growth hormone is pituitary tumor. Around 98% patient, around around 98% patients, they will have tumor in pituitary. So my treatment of choice in patients of growth hormone adenoma is surgical resection of tumor. Please remember, prolactinoma treatment, first line treatment is drugs. Growth hormone adenoma, first line treatment of choice, transpenoidal surgical resection of tumor. After surgery, I will monitor growth hormone level and IGF-1 level. After surgery, if growth hormone and IGF-1 levels are normal or decreased, then no need to do anything. But after surgery, if these levels are increasing, then I will start drugs, somatostatin analogs, octreotide, lanreotide and sandostatin, any one out of these. After starting the drug, again I will monitor growth hormone or IGF-1 level. Again they are increasing, then I will increase the dose of somatostatin analogs, plus I can add growth hormone receptor antagonist pegvisomant. Please remember the drug pegvisomant, it is MCQ. Then I can also add dopamine agonist, bromocriptine or cabergoline. It also has inhibitory effect on secretion of growth hormone. After giving drugs, still growth hormone level or IGF-1 levels are increasing, then I have to go for radiation therapy or second surgery, reoperation. It depends on the size of the tumor. Then, can you answer this? Answer this. Patient is having clinical features of acromegaly. Now, which investigation will confirm the diagnosis? They have asked confirmatory test to glucose-induced growth hormone suppression. Same question, they can ask you which of the following is screening test. Answer will become IGF-1 level. Okay. Next, adrenal gland, Cushing syndrome and Cushing disease. Now, what is meaning of Cushing syndrome? Simply remember, if your patient is having clinical features of Cushing syndrome because of excessive exposure to glucocorticoids because of any etiology. Now, what are the etiologies? Patient may have exposure to steroid. Patient is a case of any autoimmune disease which is taking steroids since 1 year, 2 year. Or patient is having adrenal tumor which is secreting lot of cortisol, or patient is having pituitary tumor which is secreting ACTH, or patient is having extra pituitary tumor like small cell carcinoma of lung which is secreting ACTH. So we are having a lot of causes for clinical features of Cushing syndrome. If patient is having clinical features of Cushing syndrome and history of or excessive exposure to glucocorticoids because of any etiology, it is a case of Cushing syndrome. Out of these all causes, if patient is having Cushing syndrome specifically because of tumor of pituitary, then you will say my patient is having Cushing disease. So please remember, in your MCQ exam, if they are using the word Cushing disease, it means they are telling you your patient is having tumor of pituitary which is secreting ACTH. Adrenal glands, they are normal, but they are stimulated by ACTH excessively, so cortisol level is increased and patient is having clinical features of Cushing syndrome. Okay. Now please remember the normal secretion of cortisol. First, hypothalamus secretes CRH, corticotropin releasing hormone. CRH stimulates corticotroph of anterior pituitary. Corticotroph cells, they will secrete ACTH. ACTH, it will act on adrenal gland. Then adrenal gland will secrete cortisol. Okay. Now, clinical features of Cushing syndrome. Very common and most important features. Central obesity. Reason, cortisol causes lipolysis of peripheral fat. Cortisol causes lipolysis of peripheral fat, and cortisol causes deposition of fat in central part of the body. So cortisol causes moon shape face, buffalo hump and central obesity. Okay. Cortisol stimulates androgen secretion. Cortisol stimulates androgen secretion. So cortisol causes hirsutism. Okay. When ACTH stimulates androgen secretion, not cortisol. ACTH stimulates androgen secretion. ACTH causes hirsutism. ACTH stimulates melanocytes. ACTH causes hyperpigmentation. Now all these are clinical features of Cushing syndrome. So remember, cortisol causes deposition of fat in central part of the body. Now, when fats are deposited below the skin, it is the rapid deposition of fat below the skin, it will cause stretching of skin. So skin, it will become thin and brittle. When fat is deposited below the skin rapidly, it will cause stretching of skin. When skin is stretched, it will cause injury to epithelium. After injury to epithelium, healing will start, and this healing, it will give you scar marks called as stretch marks. They are purple colored stretch marks. Then cortisol stimulate osteoclast, cortisol inhibit osteoblast. So cortisol, it will cause osteoporosis. ACTH stimulates melanocyte, it will cause hyperpigmentation. Then cortisol, excess of cortisol, it stimulates mineralocorticoid receptors, not normal cortisol. Excess of cortisol stimulates mineralocorticoid, means aldosterone receptors. If aldosterone receptors are stimulated, it will cause increased reabsorption of sodium plus water. It will increase intravascular fluid. It will increase blood pressure. So increase in cortisol, it will cause hypertension. Then when lot of sodium is absorbed, there will be loss of other positive charge, so there will be loss of potassium. So patient will have hypertension with hypokalemia. So in MCQ, if you are having a patient of hypertension with hypokalemia, think it can be because of increase in cortisol or increase in aldosterone. Both are possible. Cortisol inhibits hypothalamic pituitary axis HPA. So it will cause decrease in gonadotropin releasing hormone GnRH. So it will decrease libido. Cortisol, it inhibits our immune system. Cortisol inhibits our immune system, so it increases susceptibility to infection. Now, Cushing syndrome, causes of Cushing syndrome. Cushing syndrome, it is of two types, ACTH dependent and ACTH independent. Okay, very simple concept. If suppose patient is having tumor of adrenal gland, pituitary is normal, tumor is present in adrenal gland, this tumor is secreting lot of cortisol. So cortisol will increase cortisol, it will give feedback to pituitary and ACTH level will decrease. So cortisol is increasing independent of ACTH, so it is ACTH independent Cushing. Okay, second case, suppose patient is having tumor of pituitary or extra pituitary tumor, that is tumor is in the lungs. Now these tumors, pituitary or extra pituitary tumors, they are secreting lot of ACTH. Adrenal glands are normal, but they are stimulated by excessive ACTH. So cortisol level will increase, which is dependent on ACTH. So it is ACTH dependent Cushing. It is called as Cushing disease if it is because of pituitary adenoma. Okay. Now, if patient is coming to me with clinical features of Cushing syndrome, my first step, I will rule out iatrogenic Cushing. How will you rule out iatrogenic Cushing? History of drugs. If patient is having history of steroids, because of steroids, patient is having clinical features of Cushing syndrome. Now you know the cause. It is because of the drugs. We are not going to suspect tumor. So there is no need of protocol. You know the cause. But if history of drugs, it is absent, patient is having clinical features of Cushing syndrome and no history of drugs, then I have to prove that these clinical features are because of increase in cortisol. Now see, cortisol, it will increase. What are the causes? It can be because of adrenal tumor, pituitary tumor or extra pituitary tumor. Okay, in all these tumors cortisol level is increasing. So my first step, I have to prove cortisol level is increased. So I can check 24-hour urinary cortisol, I can check midnight plasma cortisol, midnight salivary cortisol, or dexamethasone overnight test. We are checking midnight plasma and midnight salivary cortisol level because at midnight cortisol level is lowest. In a normal person, cortisol secretion is lowest at midnight. That's why we are checking midnight level. Now what is dexamethasone overnight test? I will give dexamethasone, it is a steroid, it will act as a cortisol. In a normal person, dexamethasone only 1 milligram at 11 p.m. at night. This dexamethasone, it is given at 11 p.m. It will inhibit hypothalamus, HPA and pituitary. In a normal person, because of dexamethasone, secretion of ACTH will decrease, so cortisol level will decrease. Throughout the night it will occur. Next day morning at around 8 to 9 am, I will collect blood and I will measure plasma cortisol level. If I am getting low level of cortisol, then my patient is normal. There is no hypersecretion of cortisol. But after giving dexamethasone, after complete inhibition of system, if my patient is having hypersecretion of cortisol, after giving dexamethasone, cortisol level is very high. It means there are some cells present in body which are not inhibited by dexamethasone, so they are not normal cells, they are tumor cells because we cannot inhibit tumor cells. So now one thing is confirmed, my patient is having hypersecretion of cortisol. All these four are screening tests. Now still I want to confirm. So to confirm, I will inhibit complete system for 2 days. It is called as low dose dexamethasone test. Principle is same. Instead of 1 milligram, I will give 0.5 milligram of dexamethasone for 2 days. Simply, I am inhibiting the complete system for 2 days. Okay, initially I have inhibited for one night. Now I am inhibiting this system for 2 days. After 2 days, I will repeat plasma cortisol. And if I get plasma cortisol is still more than 50, now it is confirmed that my patient is having hypersecretion of cortisol. So one thing is confirmed, clinical features are present, cortisol level is increased. So these clinical features are because of cortisol. So it is a case of Cushing syndrome, but we don't know the cause. All causes are possible. Okay, it can be tumor of pituitary, ectopic tumor or adrenal gland. So my next step, I will check plasma ACTH level. Now, there are two possibilities. ACTH level, it can be increased or it can be decreased. If ACTH level, if it is increased, you will say it is ACTH dependent Cushing. ACTH dependent Cushing means if tumor can be in pituitary or ectopic. Second possibility, ACTH level is decreased. Now 100% tumor is in adrenal gland. So if ACTH level is decreased, my patient is having tumor in adrenal gland. So my next step, I want to see adrenal gland. So I will do CT scan of abdomen for CTs for adrenal gland. If tumor is bilateral, I will do bilateral adrenalectomy. If tumor is unilateral, I will do unilateral adrenalectomy. So treatment is surgery. But if my patient is having ACTH dependent Cushing, then there are two possibilities. ACTH dependent Cushing. There are two possibilities. Patient may have tumor in pituitary or patient may have ectopic tumor. Both things are possible. Both are secreting ACTH. To differentiate pituitary tumor from extra pituitary tumor, I am having three investigations. First, MRI brain. In MRI brain, if tumor is in pituitary, it is a case of Cushing disease. CRH test. I will give injection of CRH. CRH, it can stimulate pituitary tumor cells. It cannot stimulate extra pituitary cells. So after giving CRH, I will measure cortisol and ACTH. After giving CRH, cortisol increases, ACTH increases. Simply it means cells are stimulated by CRH. So these are the cells of pituitary. Your patient is having Cushing disease. After giving CRH, cortisol is not increasing. ACTH, it is also not increasing. It means cells are not responding. So they are extra pituitary or ectopic cells. Next, high dose dexamethasone test. High dose dexamethasone test. Now I will give high dose of dexamethasone. How much? 2 milligrams 6 hourly for 2 days. Remember, high dose of dexa can inhibit tumor cells of pituitary, but high dose of dexa, it cannot inhibit extra pituitary or ectopic tumor cells. I will give high dose of dexa and again I will measure cortisol level. If cortisol level decreases, it means my patient is having tumor in pituitary. After giving high dose of dexa, cortisol level is same. It means cells are not inhibited, they are ectopic cells. Okay, so these three investigation. Now after these three investigation, I can decide my patient is having Cushing disease or my patient is having ectopic tumor. Okay, so if these tests are positive, my patient is having Cushing disease. Treatment of choice, transpenoidal surgical resection of tumor. If my patient is having negative test, then my patient is having ectopic tumor. Treatment. Now if my patient is having ectopic tumor, next step I will go for CT scan abdomen and CT scan chest. Simply I want to find out the tumor. Where is the tumor? So first I will find out the tumor. After searching the tumor, I will go for surgery, treatment, surgical resection of tumor. So it is simple, but still it is not over. Climax is still pending. Suppose my patient is having one test positive, one test negative. CRH test positive, high dose dexamethasone test negative. Now it is confusing. So I will do inferior petrosal nasal, inferior petrosal sinus sampling, inferior petrosal sinus sampling, simple test. I will collect the blood from inferior petrosal sinus. Inferior petrosal sinus, it is very near to pituitary. Okay. At the same time, I will collect the blood from peripheral vein. So I am having two samples. The blood from petrosal sinus, blood from peripheral vein. I will measure ACTH level in petrosal blood and peripheral blood. Now apply your common sense. If peripheral ACTH is very high as compared to petrosal ACTH, where is the tumor? Yes, tumor is in the periphery. Okay, so it is ectopic tumor. But if petrosal ACTH is very high as compared to peripheral ACTH, patient is having Cushing disease. So it will confirm your diagnosis. Okay. Now, Harrison is giving the same thing only in the form of ratio. Harrison is telling you if petrosal to peripheral ACTH ratio is more than 2 at the baseline or more than 3 after injection of CRH, it is a positive test. You will go for transpenoidal surgical resection. But if it is a negative test, then it is ectopic tumor. Again you will go for CT abdomen, CT chest, and then you will go for surgery. Now, what is the answer for this? What is the answer for this? Very good. Cortisol is increased, ACTH it is also increased, both are increased. So it is ACTH dependent Cushing. Only two answers are possible, pituitary or ectopic. If you are able to suppress, it is pituitary. If you are not able to suppress, it is ectopic. If you are able to stimulate, it is pituitary. If you are not able to stimulate, it is extra pituitary. And this tumor is not stimulated. Very good. Answer is C. Excellent. Very good. Adrenal insufficiency, again, very simple and very important, very interesting. Primary adrenal insufficiency and secondary adrenal insufficiency. Primary adrenal insufficiency, it is called as Addison's disease. Adrenal gland is destroyed. Adrenal gland is destroyed. Primary adrenal insufficiency. Again, please remember, you have to know the normal adrenal secretions. Adrenal gland, it is having two parts: adrenal cortex, adrenal medulla. Adrenal cortex, it is having three layers: glomerulosa, fasciculata, reticularis, outside to inside, GFR. Glomerulosa, it secretes mineralocorticoid, that is aldosterone. Fasciculata secrete glucocorticoid, that is cortisol. Reticularis, it secretes dihydroxyepiandrosterone, which is a precursor of testosterone. Okay. Now, ACTH, which is secreted by pituitary, it will stimulate only FNR, only fasciculata and reticularis. It means ACTH stimulates secretion of cortisol and ACTH stimulates secretion of DHEA, which is precursor of testosterone. So ACTH increases cortisol and testosterone, but most important point, ACTH cannot stimulate glomerulosa. In a normal person, ACTH cannot stimulate glomerulosa. The basic concept you must know: glomerulosa, it is stimulated by RAS, renin angiotensin aldosterone system. Okay, so renin, it will stimulate glomerulosa, it will secrete aldosterone. Aldosterone secretion is dependent on renin normally, not on ACTH. Okay, clear? Now, if patient is having damage to adrenal gland, primary adrenal insufficiency, adrenal gland is destroyed by TB or by antibodies, it is called as TB or autoimmune adrenalitis. If adrenal glands are normal, defect is in pituitary or defect is in hypothalamus, it is called as secondary adrenal insufficiency. Now, how will you differentiate primary from secondary? When adrenal gland is destroyed, hormones of adrenal gland, they will decrease. So all the hormones of adrenal gland, testosterone, cortisol, aldosterone, all will decrease. If cortisol is decreased, pituitary is normal, it will give feedback to pituitary and ACTH will increase. And increase ACTH, it will stimulate melanocyte, patient will have hyperpigmentation. Okay, now if aldosterone decreases, it will cause loss of sodium plus water, intravascular fluids will decrease, patient will have increase in renin. So patient will have this group of hormones, increase, decrease. Now secondary adrenal insufficiency. What is the problem in secondary adrenal insufficiency? Patient is having defect in pituitary is not able to secrete ACTH, so ACTH level decreases. If ACTH level decreases, the dependent hormones on ACTH, that is cortisol and testosterone, both will decrease, but ACTH has no effect on glomerulosa, so aldosterone will be normal, renin will be normal. So these are the features of secondary adrenal insufficiency. Okay. Now, clinical features. Clinical features of adrenal insufficiency. Now, how to remember clinical features of adrenal insufficiency? Yes, you have to remember normal actions of cortisol. Normally, cortisol causes gluconeogenesis. If cortisol is decreased, gluconeogenesis will decrease and patient will have hypoglycemia. Normally, cortisol increases hunger. If cortisol is decreased, hunger will decrease. So what will happen? Patient is having hypoglycemia with decreased hunger. So patient is having hypoglycemia, but patient is not eating food. So patient will have weight loss. Normally, cortisol stimulates adrenaline synthesis. If cortisol is decreased, adrenaline will decrease. So patient will have low BP, hypotension. Normally, cortisol inhibits HPA, hypothalamic pituitary axis. So normally, cortisol decreases TRH and decreases TSH. Okay. Similarly, cortisol inhibits HPA. So cortisol inhibits antidiuretic hormone ADH. I want to tell you cortisol is inhibiting HPA. So cortisol is decreasing TRH and cortisol is decreasing ADH. If cortisol is lost, cortisol is gone, then TSH will increase, ADH it will also increase. If ADH increases, action of ADH, it is reabsorption of water, only water, not sodium. Lot of water will be absorbed, it will be added to serum, serum will be diluted, patient will develop dilutional hyponatremia. These are the features of decreased cortisol. If patient is having decreased androgen, if patient is having decreased testosterone level, then patient will have loss of libido, loss of axillary and pubic hairs. Then decrease aldosterone, it will cause decrease sodium, water, decrease intravascular fluid, it will cause decrease in BP, hyponatremia and hyperkalemia. Now patient is coming to me with clinical features of adrenal insufficiency. Now first I will check cortisol level. To check cortisol level, first I will give injection of CRH. After giving CRH, if cortisol level is low, then my patient is having adrenal insufficiency. Okay, one thing is confirmed that cortisol level is decreased. Now I want to confirm, is it primary or secondary? So I will check ACTH, renin and aldosterone. If ACTH is increased, it means pituitary is normal, it is secreting ACTH, defect is not in pituitary, defect is in adrenal gland, so it is primary adrenal insufficiency. In primary adrenal insufficiency, we have to treat decreased cortisol and decreased aldosterone. Okay, so we will give glucocorticoids and mineralocorticoids. Okay, mineralocorticoid means fludrocortisone, glucocorticoid means hydrocortisone, dexamethasone, prednisone, prednisolone. Next, secondary adrenal insufficiency. Secondary adrenal insufficiency, defect is in pituitary, ACTH will decrease, aldosterone renin will be normal. Which drug is not required? Please remember fludrocortisone, that is mineralocorticoid, it is not required. Now what is the answer for this? Yes, Shinder, very good. Okay, answer is low renin level. Answer is low renin level. Hyperaldosteronism, again it is primary and secondary. Primary hyperaldosteronism, it means my patient is having adrenal tumor. Tumor is secreting lot of aldosterone independent of everything. Aldosterone, it will reabsorb the sodium plus water. It will increase intravascular fluid. Increase intravascular fluid, it will go towards kidney. Kidney is getting lot of intravascular fluid, so renin level will decrease. Now most important point here, if aldosterone level, if it is increasing and renin level is decreasing, it means aldosterone secretion is independent of renin. Okay, in practice we measure aldosterone renin ratio. Aldosterone increasing, renin decreasing, so aldosterone renin ratio will increase. Simply aldosterone secretion, it is independent of renin. Secondary hyperaldosteronism, it is because of vomiting, diarrhea, congestive cardiac failure, nephrotic syndrome. Here intravascular fluids are decreased. Decrease intravascular fluid, they will go towards kidney. Kidney will stimulate RAS, renin will increase, and it will cause increase in aldosterone, and it will cause increased absorption of sodium plus water. Simply remember, in secondary hyperaldosteronism, aldosterone secretion is dependent on renin. When aldosterone and renin both increases, your patient is having secondary hyperaldosteronism. Now, primary hyperaldosteronism, it is because of tumor of adrenal gland. Okay. MCQ, what is Cone syndrome? What is Cone syndrome? adrenal adenoma secreting lot of aldosterone, it is Cone syndrome. Okay, secondary hyperaldosteronism is because of vomiting, diarrhea, CCF, nephrotic syndrome. In primary hyperaldosteronism, patient will have hypertension with hypokalemia. Lot of sodium is absorbed, so there will be loss of positive charge H plus ions. H plus ions are lost from the body. Patient will have metabolic alkalosis. Clinical feature of metabolic alkalosis, it is cramp. Okay. MCQ, which of the following is not a clinical feature of increased aldosterone or primary hyperaldosteronism? Please remember, edema is not a feature. Edema is not the feature of primary hyperaldosteronism, that is Cone's syndrome. Because of aldosterone escape mechanism, it is not given in Harrison. It is very simple. Lot of aldosterone, it will reabsorb lot of sodium plus water, and it will increase workload on heart. So now heart will release natriuretic peptide. It will cause natriuresis, loss of sodium plus water, and because of increased natriuretic peptide, fluid and sodium will be lost. It will compensate. Okay, now what is important for us? Ratio of aldosterone to renin called as plasma aldosterone to plasma renin activity. If this ratio is more than 30 with plasma aldosterone more than 20, your patient is having primary hyperaldosteronism. So now one thing is confirmed, that aldosterone secretion is independent of renin. It is independent of renin. But now I want to confirm these are tumor cells. So how will you confirm that these are tumor cells? By you will try to inhibit these cells. How will you inhibit cells? You will give lot of saline. In a normal person. If I give saline, I am increasing intravascular fluid. It will go to kidney, and kidney will decrease renin, and then aldosterone will decrease. So in a normal person, after giving saline, aldosterone level decreases. After giving saline, if aldosterone level is very high, simply it means we are not able to inhibit cells. So they are tumor cells. Similarly, I can give lot of salt. Oral sodium loading test. After giving lot of salt, normal person will have decrease in aldosterone. After giving lot of salt, if aldosterone level is high, my patient is having tumor cells. Fludrocortisone suppression test. I will give the drug fludrocortisone. After giving fludrocortisone, I will measure plasma aldosterone. If it is increased, my patient is having tumor. Now, I am suspecting primary hyperaldosteronism. So, tumor is in adrenal. I will do CT scan of adrenal. There are two possibilities. Tumor can be unilateral, tumor can be bilateral. If tumor is bilateral, then treatment is only drugs. Aldosterone antagonists, spironolactone, or sodium channel blockers, amiloride. If tumor is bilateral, only drugs are sufficient. No need of any surgery. Okay. But if tumor is unilateral, then there are two possibilities here. Now we will see age of the patient. If age of the patient is less than 40, then unilateral active adenomas, they are common. So you will directly go for surgery, unilateral adrenalectomy. But if age of the patient is more than 40, then unilateral non-active adenomas, they are more common. It means CT scan is showing you adenoma, but CT scan is not telling you is it secreting the hormone or it is not secreting the hormone. Okay. So in these patients, non-active unilateral adenomas are common. So this adenoma can be inactive. Now what is common in this patient? In this patient, bilateral small tumors, they are common. Then why CT scan is not showing them? Because CT scan miss the lesion if it is less than 5 mm. So my patient may have bilateral active tumors and their size is less than 5 mm and they are secreting aldosterone, but CT scan is not able to detect them because their size is very, very small. So now I am having two possibilities. My patient may have unilateral active adenoma, which is secreting aldosterone, or bilateral active small tumors, which are secreting aldosterone. I want to differentiate unilateral from bilateral, because if tumors are bilateral, treatment will be drugs. If tumors are unilateral, treatment will be surgery. So I will do adrenal vein sampling. If my adrenal vein sampling means I will collect the blood from right adrenal vein and left adrenal vein, okay, and then I will compare the plasma aldosterone in both adrenal vein plus IVC, inferior vena cava, okay. If plasma aldosterone is increased only on one side, CT scan is showing adenoma on right, and right adrenal vein is having very high level of aldosterone, it means aldosterone is coming only from the adenoma, so treatment will be surgery. But if plasma aldosterone is increased in both adrenal vein, right and left adrenal vein, then aldosterone is coming from the both sides, so treatment will become surgery. So that's why it is very important to differentiate unilateral and bilateral if age is more than 40. Okay, in exam they will give you a patient with clinical features of hyperaldosteronism. They will tell you CT scan is showing unilateral adenoma, age of the patient is more than 40, what will be your next step? Answer, adrenal vein sampling. Same patient they will give you and they will ask you age of the patient is less than 40, what will be your next step? No, your answer will be unilateral adrenalectomy. Now answer this question, very simple one. So hypertension with hypokalemia with increased aldosterone and decreased renin, it is a case of Cohen's syndrome. It is a case of Cohen's syndrome. Very good. Now ADH, antidiuretic hormone. In ADH we have to learn diabetes insipidus. Okay, you should know the normal mechanism of ADH. ADH secreted by hypothalamus stored in pituitary. When pituitary is storing ADH, it looks like a bright spot. So normally pituitary has a bright spot in MRI. Whenever required, ADH will be secreted. It will stimulate V2 receptors on distal part of nephron. When V2 receptors are stimulated, they will form aquaporin channels and they will reabsorb water molecules. Water molecules will be absorbed from the distal part of nephron and water molecules will be added to serum. So simply I will say, when ADH is acting on kidney, it will reabsorb the water from urine and urine will be added to serum. So it will dilute the serum and it will make urine concentrated. So what will happen? If ADH is present, water will be shifted from urine to serum. Now what is the diabetes insipidus? There are two types of diabetes insipidus, central diabetes insipidus and nephrogenic diabetes insipidus. In central diabetes insipidus, pituitary is having a defect. Pituitary is not able to secrete ADH, ADH level decreases, V2 receptors not stimulated, water molecules cannot be absorbed. So water which is entering in kidney from serum, it will be lost in urine. So water is shifted from serum to urine. So it will increase serum osmolarity. Water is added to urine. Urine will become diluted. Urine osmolarity will decrease. In nephrogenic diabetes insipidus, patient is having defect in a V2 receptors. It means pituitary is normal, pituitary is secreting ADH, but receptors, they are not responding to ADH. So ADH level will increase but not able to stimulate V2 receptors. So kidneys, they are not able to reabsorb water. So water molecules from serum, they will be lost in urine. So again same thing will happen. Serum osmolarity will increase, urine osmolarity will decrease. So please remember, in central diabetes insipidus and nephrogenic diabetes insipidus, serum finding and urine findings, they are same. Clinical features: if serum osmolarity increases, it will stimulate thirst center in brain, so it will cause polydipsia. if lot of water is going towards kidney but kidney is not able to reabsorb the water, patient will have polyuria. Both patients will have same clinical features, same serum finding, same urine finding. Only differentiating point is ADH. Central diabetes insipidus ADH decreases, nephrogenic diabetes insipidus ADH increases. Now my question to all of you, you have to listen carefully and give me the answer. Pituitary bright spot. In nephrogenic diabetes insipidus, pituitary bright spot will be present or absent. Give me the answer fast. In nephrogenic diabetes insipidus, pituitary bright spot will be present or absent. So all of you are saying present. So please remember, pituitary bright spot present, it is the most common wrong answer. Pituitary bright spot present, it is the most common wrong answer. Again I am telling you, apply your logic. What is meaning of bright spot? What is meaning of bright spot? Bright spot is stored ADH in pituitary. In nephrogenic diabetes insipidus, V2 receptors, they are not working. So pituitary will store ADH or pituitary will release ADH. Excellent. Now you are getting the correct answer. Pituitary is releasing ADH. Sentence from Harrison. In nephrogenic diabetes insipidus, pituitary bright spot can be absent because of increased turnover of ADH. Next MCQ. Pituitary bright spot cannot differentiate central from nephrogenic diabetes insipidus. Only ADH level in serum it can differentiate central from nephrogenic diabetes insipidus. Okay. Next, psychogenic polydipsia. Now my patient is having obsessive compulsive disorder, OCD of drinking water. Now patient is drinking water continuously. It is a psychiatric disorder. Pituitary normal, kidneys normal. Patient is drinking lot of water. So lot of water is entering in GIT. GIT will reabsorb the water. Water will enter in serum. Serum osmolarity will decrease because serum will be diluted. Diluted serum, it will give feedback to pituitary that lot of water is present in blood. There is no need to reabsorb the water. So now pituitary is getting feedback from serum osmolarity and now pituitary will decrease ADH level. So kidneys, they are not going to reabsorb the water. Diluted serum, it will go towards kidney but ADH is not there. So kidneys are not able to reabsorb the water. So water will be lost in urine. Water is added to urine. Urine will be diluted. Urine osmolarity will decrease. Simply remember, if everything is decreased, ADH decrease, serum osmolarity decrease, serum sodium decrease, urine osmolarity, urine sodium, it is also decreased. If everything is decreased, your answer is psychogenic polydipsia. Now, if patient is coming to you with polyuria and polydipsia, my next step, I will check the volume of urine. Next, I will check the urine osmolarity. If urine osmolarity is decreased, urine is diluted, lot of water is present in urine, I am having three differential diagnoses. It can be central diabetes insipidus, nephrogenic diabetes insipidus, or psychogenic polydipsia. So in whole endo, our first step is check the hormone level. I will check ADH level. If ADH level is increased, it means pituitary is working but kidneys are not responding to ADH. Defect is in kidney. Answer is nephrogenic diabetes insipidus. Treatment is thiazide, amiloride and indomethacin. But if ADH level is decreased, then defect is in pituitary. Pituitary is not secreting ADH. Or patient may have psychogenic polydipsia. So I will do MRI brain, and if in MRI brain pituitary bright spot is absent, it is a case of central diabetes insipidus, and if bright spot is present, it is a case of primary polydipsia. Next is water deprivation test. I will check urine osmolarity and then I will start water deprivation. Don't allow the patient to drink water. After water deprivation, urine osmolarity improves, patient becomes normal. It is a case of primary polydipsia. After water deprivation, still urine osmolarity is unchanged, then my patient is having diabetes insipidus. So I will give ADH or I will give desmopressin, and again I will measure urine osmolarity. If it becomes normal, it is a case of central diabetes insipidus. After ADH, still urine osmolarity is unchanged, then it is a case of nephrogenic diabetes insipidus. Now SIADH means increased secretion of ADH. Syndrome of inappropriate secretion of ADH, that is increased ADH. Normally ADH reabsorbs the water. When lot of water is absorbed from the from the urine osmolarity, urine sodium will increase, water will be added to serum, so serum will be diluted, so serum osmolarity and sodium will decrease. Now these patients, they will come to you with clinical features of hyponatremia, confusion, seizure, headache, vomiting, but edema is absent. Why edema is absent? Compensatory mechanisms are there. Increase water in serum, it will increase workload on heart. Again heart will release natriuretic peptide, it will compensate and it will prevent edema formation. Increase intravascular volume, it will go towards kidney, and renin will decrease. Decreased renin will cause decreased aldosterone, and it will cause loss of sodium and water. Next theory says there is vasopressin escape mechanism. When ADH level increases, this high level of ADH, it is continuously stimulating V2 receptors, and the time will come when all V2 receptors, they will become saturated and they will stop responding to ADH, and there will be loss of water. Now treatment. Water deprivation. First step, water deprivation, then you will give oral furosemide plus salt, then demeclocycline. Still no response, you will give tolvaptan. It is V2 receptor antagonist. Then what is the answer for this? Patient, what is the best value for nephrogenic diabetes insipidus? If there is nephrogenic diabetes insipidus, ADH level will increase. So answer is between A and C. ADH level is increased, but it is not able to act on kidney. So kidneys are not able to reabsorb the water. Water will be lost in urine. Urine osmolarity will decrease. Serum osmolarity will increase. Answer is A. Okay. Diabetes mellitus, most important is diagnostic criteria of diabetes. If patient is having symptoms of diabetes plus random blood sugar more than 200 or fasting blood sugar more than 126, HbA1c more than 6.5 or ppbs more than 200, if any one out of these four are present, it is a case of diabetes. Now what are the normal glucose levels? FBS less than 100, HbA1c less than 5.6, 2-hour plasma glucose less than 140. These are normal levels. Now what is meaning of pre-diabetes? Pre-diabetes means if sugar levels, they are in between 100 to 125 fasting, and HbA1c between 5.5 to 6.4 and ppbs between 140 to 199. This is the pre-diabetic state, and here diabetes is diagnostic criteria of diabetes. Now these three definitions, they are added in Harrison. Fulminant diabetes. If patient is having viral infection of pancreas which is damaging islet cells of Langerhans, beta cells are damaged by viral infection, so insulin secretion decreases, patient will have fulminant diabetes. Then atypical diabetes. Patient is a case of type 2 diabetes, but the age is less than 30. Okay, generally type 2 normally type 2 diabetes occurs after 30 years of age, but if it is occurring before 30 years of age, it is atypical diabetes. Okay, if type 2 diabetes, if it is occurring in a thin patient, then it is atypical diabetes. Ketosis prone diabetes. Patient present to you with ketoacidosis but do not require long-term exogenous insulin therapy. Okay, so what is happening normally, type 1 diabetes, they are having very high risk of diabetic ketoacidosis and they need lifelong insulin therapy. But these patients, they will present to you as a ketoacidosis, but insulin is not required. They will give good response to drugs. So it is ketosis prone diabetes. Then mutant INS gene induced diabetes of youth. Simply, if patient is having some genetic defect which is responsible for defect in insulin synthesis, it is called as mutant INS gene induced diabetes of youth. Okay, now type of diabetes. These are the very basic points: type 1 diabetes and type 2 diabetes. Type 1 diabetes, it occurs before 30 years of age. Generally patients are thin, generally ketone bodies are present, and only treatment is insulin. These patients, they will give no response to oral drugs. Type 2 diabetes, these patients age group is more than 30 years, obesity increases peripheral resistance to insulin, and initially you will give oral drugs. These patients, they will give respond to insulin, they will give respond, but insulin, it is not the first line treatment. Here first line treatment is oral drugs. Now there are some diabetes which are having common features of type 1 and type 2. They are called as 1.5. So 1.5 ketosis prone diabetes, age of the patient is less than 30 years, but patient is obese. Less than 30, feature of type 1 diabetes. Obesity, feature of type 2 diabetes. Ketone bodies present, type 1 diabetic feature. Insulin response, initial treatment is not insulin, they will give response, but initially they also give response to OHA. They are giving response to OHA, it is a feature of type 2 diabetes. So there is mixed features of type 1 and type 2. Then 1.5 LADA, latent autoimmune diabetes in adults. Features: age more than 30 years, feature is of type 2 diabetes. Thin patient, feature of type 1 diabetes. Ketone bodies negative, feature of type 2 diabetes. Insulin response positive, feature of type 1 diabetes. No response to OHA, it is a feature of type 1 diabetes. Okay, then maturity onset diabetes of young. Simply remember what is maturity onset diabetes of young. Maturity onset diabetes of young, there is some genetic defect in beta cell. Number of beta cells are normal. Because of some genetic defect in beta cells are not able to synthesize insulin. It is MODI, maturity onset diabetes of young. Okay, MIDS, defect in INS gene, which is MIDY. Okay, so both are different, slight difference is there. Just remember definition, just remember basic points which are given in Harrison. Now these are our treatment goals. We want to decrease HbA1c below 7, FBS below 130, PPBS below 180. In type 2 diabetes, we will start the treatment with diet, exercise and metformin. Then we will reassess HbA1c. If HbA1c is still more than 7%, I will add second drug with different mechanism of action. After starting second drug, if sugar levels are not controlled, best is to start insulin, but most of the patients, they will refuse. So you can use second, third and fourth drug. Maximum you can give 4 drugs with different mechanisms of action. After giving 4 drugs, if still sugar levels are not controlled, you have to give insulin. There are no options. Now in drugs, I am giving you list of drugs. You must know mechanism of action of all drugs, and you must know contraindications of all drugs. Before giving drug, you will check the contraindication. For example, if my patient is having renal disease or liver disease, I will not give Hoglibos. So you will check LFT, RFT, then you will plan for Hoglibos. Okay, so before giving drugs, you have to check its contraindication or complication. Now, insulin, important point, in new Harrison, inhaled human insulin is added. Inhaled human insulin, it was not there in old Harrison, it is added in new Harrison. Then degludec, it was not there in old Harrison, it is added in new Harrison. MCQ, longest acting insulin is, answer is degludec according to new Harrison. Old Harrison, according to old Harrison, glargine was longest acting insulin. Then you should know all points of regular insulin. Onset occurs within 30 minutes or in 30 minutes, peak in 2 to 3 hours, and effect of regular insulin, it is 4 to 8 hours. Next, this is the table from New Harrison. In New Harrison, recent edition 21st, euglycemic diabetic ketoacidosis, this term is added. Euglycemic diabetic ketoacidosis, all points of euglycemic decay, all points of euglycemic decay, they are same as diabetic ketoacidosis. Only one difference is it is euglycemic, means sugar level it is normal or less than 250. It is the only one difference. Other all points are same as DKA. Then what are the differentiating points? What are the differentiating points of HHS and DKA? Simply remember, in DKA ketones are present. Patient will have clinical features of ketones and clinical features of acidosis. In HHS, ketones will be absent or very or present in a very small amount that they cannot give clinical feature. In HHS, ketones are absent or very mild that they cannot cause acidosis. Okay, so all features of ketones will be absent, acidosis will be absent. MCQ. Okay, so which of the following cannot differentiate DKA from HHS? It is magnesium chloride and phosphate. Okay, read the MCQ. Okay, serum chloride level. Potassium can differentiate. Potassium can differentiate. Which of the following cannot differentiate? Serum chloride level cannot differentiate. Parathyroid. Now, parathyroid, most primary hyperparathyroidism. Normally what happens when parathyroid gland secretes PTH, PTH acts on osteoblast, osteoblast stimulate osteoclast, osteoclast it will cause destruction of bone. Then this destruction of bone, it will release calcium and phosphate. This calcium and phosphate, it will go towards kidney. In presence of PTH, kidney will reabsorb the calcium and it will cause excretion of phosphate. Okay, so normal effect of PTH, reabsorption of calcium, excretion of phosphate. So it will increase serum calcium, it will decrease serum phosphate. Now, clinical features of primary hyperparathyroidism. In primary hyperparathyroidism, lot of bones are destroyed, so patient will have severe pain. There will be inflammation of bone, osteitis, fibrosis of bone, fibrosa, cyst formation in bone, cystica. When osteoclasts are stimulated, osteoclasts, they will cause rupture of capillaries and there will be hemorrhage formation in bone. Hemorrhage in bone, it is called as brown tumors. So brown tumors, it is a misnomer. Brown tumor, it is a misnomer. It is not a tumor. It is the hemorrhage in bone. Then Ruger-Jersey spine. When vertebrae are destroyed, central part is severely destroyed, peripheral part is less severely destroyed. So there will be alternate bands of white and black colored. It looks like a jersey. Salt and pepper, appearance of skull. Now, if all these clinical features are present, you are suspecting hyperparathyroidism. Your first step, you will check serum PTH level. If serum PTH level is increased, you are suspecting a parathyroid tumor. You will do cystamebi scan. Cystamebi scan, it will find out the tumor. Treatment is surgical resection of the tumor. For hypercalcemia, you will give lot of IV fluid followed by forced diuresis, then pamidronate, zolendronate, they will inhibit osteoclast cell. Calcitonin, it will shift the calcium from blood to bone. And last option is dialysis. Next, pseudo-hypoparathyroidism. It is pseudo-hypoparathyroidism. Focus on first three patients, PHP 1A, 1B and 2. First three patients, they will come to you with clinical features of hypocalcemia. Okay, so now patient is coming to me with clinical features of hypocalcemia. So I will check serum calcium and serum phosphate, and I got calcium level decrease, phosphate level increase. Calcium decrease, phosphate increase. So now I am suspecting hypoparathyroidism. I am suspecting hypoparathyroidism. So I will check serum PTH level. Okay, I am expecting that PTH level should be decreased, but I got PTH level is increased. So now I am suspecting PTH level is increasing, but it is not able to reabsorb calcium. So my patient is having defect in receptor. So I want to check the receptor. So I will check urinary cyclic AMP. Okay, and if receptors are normal urinary cyclic AMP, they will be excreted in urine. I got urinary cyclic AMPs are decreased. It means receptors are defective, and defect is in GS alpha subunit of PTH receptor. And this defect, GS alpha defect, it is associated with AHO, Albright hereditary osteodystrophy. Clinical features of AHO: short stature, round face, short fourth and fifth digits. Okay. Next patient is again coming to me with clinical features of hypocalcemia, calcium decrease, phosphate increase. So I thought it is a case of hypopara, or it can be a case of pseudo hypopara. So I have checked PTH, and again I got PTH is increased. So it is a case of pseudo hypoparathyroidism. Okay. Now again I will check urinary cyclic AMP. Cyclic AMP levels are decreased. So receptor is defective, but AHO is absent. AHO is absent. Defect is in receptor but not in GS alpha. This time defect is in some other subunit of receptor, which is GNAS. Next, PHP2. Again patient will come to me with clinical features of hypocalcemia, calcium decrease, phosphate increase. I thought it is hypopara or pseudo hypopara. I have checked PTH. PTH level is increased. Now this time I got urinary cyclic AMP increase. It means receptor is working. PTH is increased, receptor is working. After stimulating receptor, PTH is not able to reabsorb the calcium, not able to excrete the phosphate. So defect is distal to the formation of urinary cyclic AMP. Name of the defect: distal to cyclic AMP. Last patient. This patient came to me with clinical features of AHO, short stature, round face. So I thought it is a defect in GS alpha. Yes, I am correct. Defect is in GS alpha. So I thought it is a case of pseudo hypoparathyroidism type 1A. To confirm my diagnosis, I have checked calcium, phosphate, PTH and cyclic AMP, but everything was normal. So it is not the case of PHP1A. It is a case of PPHP, pseudo hypoparathyroidism. Defect it is in the subunit of gene, GS alpha gene, which is controlling only skeleton. It is controlling the development of skeleton. Okay. Next, what is the answer for this? Relationship between urinary cyclic AMP and PTH receptor. If PTH receptor is normal, PTH will act on PTH receptor and it will cause release of cyclic AMP in urine. If there is defect in receptor, cyclic AMP will decrease in urine and PTH will increase in blood. Very good. Answer is PHP2. Last topic, thyroid. You must know clinical features of hyperthyroid, hypothyroid. Hyperthyroid patients are always restless, anxious. They will have insomnia. Opposite will happen in hypothyroid. They will have depression. They will have weight gain. Then in hyperthyroid, T3, T4 stimulates beta 1 receptors on heart rate will increase, patient will have tachycardia, increased risk of atrial fibrillation, palpitation. Heart rate increases, heart rate multiplied by stroke volume is equal to cardiac output. So systolic BP will increase. Opposite will happen in hypothyroid. Okay, so I am not going in detail of clinical features. What is important for us? Diagnosis. In exam they will give you the table or they will give you a clinical scenario. Patient is having decreased T3, T4. So your patient is a case of hypothyroid. Now I want to check it is primary or secondary. So I will check TSH. If TSH is increased, it means pituitary is working. Defect is not in pituitary. Pituitary is secreting TSH. Still thyroid gland is not able to secrete T3, T4. So it is a case of primary hypothyroidism. T3, T4 decrease, TSH it is also decrease. It means pituitary is not secreting TSH. So defect is in pituitary. It is secondary hypothyroidism. Then hyperthyroid, T3, T4 increase means hyper. Now if TSH is decreased, still pituitary is secreting T3, T4. It is like a tumor. It is like a tumor of thyroid gland secreting lot of T3, T4 independent of TSH. It is primary hyper. Okay. If T3, T4 is increased because of TSH, it is secondary hyper. Now causes of primary hypothyroidism. Antibodies, they are destroying the thyroid gland. Hashimoto's thyroiditis. Hashimoto's thyroiditis, antibodies are anti-TPO antibodies and anti-thyroglobulin antibodies. Iodine deficiency and infiltrative disorders. Now we will check TSH, T3, T4. If you get T4 decrease, TSH increase, it is primary hypothyroidism. In these patients, you will check anti-TPO antibodies. If antibodies are present, you will treat with levothyroxine and steroid. But if antibodies are absent, you will try to find out the cause and you will treat the cause. Then if T3, T4 normal, TSH is increased. T3, T4 normal, so patient will not have clinical feature. That's why it is called as subclinical hypothyroidism. TSH is increased, so extra amount of TSH is required to maintain normal T3, T4. In this patient, we will check antibodies and symptoms. If antibodies and symptoms are present, you will treat. If antibodies and symptoms are absent, no need of treatment. Okay. Primary hyperthyroidism, 3 important causes: Graves' disease, toxic MNG, toxic adenoma. Okay. Now in these patients, we will check TSH and T4. If your patient is having normal T4 and TSH is low, it means what is happening here? TSH is low, T4 is normal. Simply, thyroid gland is maintaining normal T3, T4 without help of TSH. TSH is not required. Without TSH, thyroid gland is secreting T3, T4. So, it is subclinical hyperthyroidism. In subclinical hyperthyroidism, patient will not have symptoms because T3, T4 levels are normal. No need of treatment, just follow up. After a few months, this patient will develop primary hyperthyroidism. But if our patient is having low TSH and T4 is high, now it is primary hyperthyroid, then I am having 3 differential diagnoses: Graves' disease, multinodular goiter and toxic adenoma. Okay. Now if my patient is having primary hyperthyroidism, I will check these 5 points. Please remember, these 5 points are given in Harrison. Okay. If patient is having diffuse goiter, now see, antibodies are present only in Graves. Which antibodies? Anti-TSH receptor antibody and anti-TPO antibody. But anti-TSH receptor antibody, it is main antibody, it is dominant antibody. Anti-TPO antibody, it is not dominant. In lab test, in blood test, you can get anti-TPO antibody present because it is autoimmune disease. Okay. Anti-TSH receptor antibodies, they will stimulate all receptors. Receptors are present throughout the thyroid gland. So complete thyroid gland, it will become hyperactive. So there will be homogeneous distribution. Diffuse goiter will occur. So diffuse goiter, presence of antibodies. Antibodies, they will attack on retroorbital tissue. So there will be inflammation behind eyeball, swelling behind the eyeball, retrobulbar. So what will happen? Because of swelling behind the eyeball, there will be proptosis. Same antibodies, they will attack on skin. Patient will have orange color skin called as pretibial myxedema. Antibodies are present only in Graves. So if these features are present, antibodies are present, your patient is having Graves' disease, no need of any further investigation, directly start the treatment. Okay, remember 3 terms: myxedema, myxedema coma and pretibial myxedema. What is myxedema? It is non-pitting edema seen in hypothyroidism. Okay. What is myxedema? Coma. Severe case of hypothyroid, it is myxedema coma. And pretibial myxedema, it is seen in Graves' disease only. It is specific for Graves. It is a red orange color rash on skin because of antibodies. Now, if these 5 features are absent, now your patient is having toxic adenoma or multinodular goiter. To differentiate these two things, you will do radioisotope scanning, thyroid scan. Thyroid scan will differentiate. Okay, just for your knowledge, I am giving you all four features. So first one is normal. This is the normal thyroid gland, normal uptake of iodine. This is normal thyroid. Second one is Graves. Complete thyroid gland is hyperactive, homogeneous distribution. This is multinodular goiter, multiple nodules are present. And last one is single large nodule, large adenoma, only one nodule is active, toxic adenoma. Treatment is same in all. First you will give anti-thyroid drugs for symptomatic relief, beta blocker, then radioiodine, and last step is surgery. Okay, and what is the answer for this? Only figure can give you the answer, multinodular goiter. Okay, so all these MCQs are your homework. You will solve the MCQs. Okay, and just all the best for your exam. Because of short time I have gone fast. If you have any doubt, you can ask me anytime. You can follow my Insta channel or you can ask me doubt on Facebook. If you want my phone number, it is 9577010313. Okay, so all the best for your exam. Thank you very much for your patience. Are you satisfied? Okay, all the best. So thank you very much. I will be very happy if you give your feedback, and all the best for your exam. If you have any doubt, you can ask me anytime.